Hello and welcome to paramedicine.com.
Translating research into practice.
I'm Mark Colbeck at the ACU Sound Recording Studio in Queensland, Australia.
And I'm Sonia Maria in New South Wales, Australia.
And this is episode 4, the respiratory assessment.
Okay, so in the previous podcast, we've covered the primary survey and the secondary survey, and Mark did a wonderful head-to-toes assessment as a part of our secondary survey as well, including that nice little video. Mm-hmm. And now we're going to be moving on to a series of new assessments. We're not sure exactly what they're going to be yet, but we assume that there's probably going to be around half a dozen of them, and they'll be covering things like neurological exam, cardiovascular, abdo, GI, etc., those kind of things. Now, with each one of these ones, we're probably going to have a bit of a structure to them, and I'll let Mark talk about that. And today's podcast is specifically on the respiratory exam, or the respiratory assessment.
Yeah, so assessment, we use the word assessment because we're including both the interview that we do of the patient, the verbal part, talking to them, and we're doing the the specific signs that we see from the patient. So signs and symptoms, really, what the patient's complaining of, what we notice in the environment and their history, and also what we notice during the physical exam. So we're going to be doing both of those. We've got a structure for how to organize yourself mentally with both of those. And in terms of the questions that we're going to ask and the assessment that we're going to be going through, we've got a bit of a gas flow review. That's the sort of the format I'm thinking of. If you think about it, the oxygen molecule floats around us in the atmosphere, then it has to be drawn in through the mouth, down through the airway, into the alveoli, across the respiratory membrane, into the blood, onto the red blood cell, travel through the blood, and then eventually get down to the cell itself, where we have cellular respiration. So when you're thinking what could be causing the problem with their breathing, we're going to go from the outside in and do that gas flow review. To organize the physical exam, we've actually got a bit of an alphabetical structure, which you'll hear, which sounds a bit crazy when you first hear it. You think, I'll never remember that. But really, with a bit of practice, you can actually get through it all and remember it well. And at the end of the podcast, we're going to be presenting 3 patients, and we'll simply present those physical findings in this alphabetical mnemonic that we've got. And you'll be able to see that it's really quite clear what's wrong with the patient if you include all of those signs that we're assessing for.
Okay, so Mark was talking about the environment as being the first place or the first problem that a patient might have with getting oxygen into their body. So when we talk about the environment, we could be talking about the amount of oxygen actually in the atmosphere. And a few things that might relate to that could be altitude. So the person might be at a great height. So for instance, think about high altitude pulmonary edema, or a problem with being at a great height or a lack of oxygen in the air. The air density and concentration changes as we go up higher. So there may be a change in the dynamics of the amount of oxygen in the air also. But that could also happen, for instance, in a building fire. So you might find in a building fire the amount of gas available in the air changes, normal levels of oxygen versus carbon monoxide, etc., change. So the environment can be an actual problem for the patient, just trying to get oxygen actually into their body. So less oxygen level in the environment, that's obviously an issue. The other thing I can think of that we might encounter sometimes could be someone trapped in a small space. So they might have actually used up a lot of oxygen and now be rebreathing air at a concentration that's not normal.
Yeah. Or if they're in a low, like in a mine or something, and some sort of heavier gas comes down and displaces the oxygen, which is a whole specialty in itself. But yeah, that's obviously an issue.
Yeah, the other thing I could think of too is maybe diving, the mixture of gases that sometimes they play with when they do diving. So that may be intentional, maybe an intentional change in the actual gas that they're inhaling as well.
Right. Or hyperthermia obviously will affect our brains, or hypothermia.
Yeah.
So if we have environmental factors like that, yeah, for sure. And then when we have the oxygen gas outside, we need to draw it in through to our body. So part of that is our brain's control of that. And I kind of think of that as the head. It's got to go through the head, and that's all controlled by the brain. So raised intracranial pressure could obviously be a problem if we start getting into Cushing's reflex and people are breathing abnormally because we're compressing the brain stem.
Mm.
Brainstem infarcts, for example, if you've got a brainstem stroke, that's something to think about. And if you're, curious about something like that, that's not really something you could say, are you having a brainstem stroke right now? It's like, no, actually, it's more, thalamus, or, and people aren't going to know. So what we could do is start guiding our assessment, maybe assessing cranial nerves, maybe looking for evidence of Cushing's reflex, just making sure that all evidence that we have is that the brain is still working okay, they're alert, they're oriented, they have memory, all that sort of stuff. And of course, CNS stimulants or depressants are going to affect people's respiratory function. Somebody on cocaine is going to breathe pretty fast. Somebody with a lot of heroin might not be breathing at all. So we can investigate that in our history. And also, one of the other drugs that I think about, particularly when I think about hyperventilation, is aspirin, because aspirin overdose gives us a metabolic acidosis that drives people to want to blow off that acid, but they can't because it's a metabolic acidosis. And you'll see that aspirin overdoses are often really hyperventilating. And of course, another reason for hyperventilation could be anxiety, could be voluntary, sort of like a psychosomatic hyperventilation syndrome, which is always our last diagnosis. It's a diagnosis of exclusion. But the breathing is controlled by the brain. So have a think about their brain and ask yourself, is there any indication that their brain might not be working properly?
Good. Yeah, that's really interesting. Thanks, Mark. So when we move through the head, we're obviously beginning in the airway. So the airway is obviously the first entry point into the body. And when we start thinking about the design of the airway in both adults and children, you've got to sort of flick that a little bit differently, think a little bit differently for children. But certainly when we're talking about airway, you're starting to think with the airway, is there any obstruction first when it comes in through the mouth and then makes its way down into the lungs? Is there anything obstructing the flow? So it could be a foreign body, or it could be swelling, or a tumor, or spasm like laryngospasms. So some of the disease process that go with that, especially for children, we're thinking of things like croup or epiglottitis.
Right.
And in older people, it might be COPD or airways limitations, depending whatever your flavor is and whatever you want to call it.
Yeah.
Anaphylaxis, asthma.
Sure.
Pulmonary edema. Tracheal stenosis is another problem. Some people may have varices or all kinds of damage to the throat structure, the larynx and the pharynx. And also, when you think about that, any kind of inflammation, infection, anything that's going to affect the respiratory tract, so pneumonia, anything that can come up can go down too.
And that's the swelling and spasm you were talking about before, with anaphylaxis and angioedema. And right.
Yeah, they're all related in an infective process too. So moving down, going into the actual lungs, we're thinking things like pneumothorax, any kind of damage to the lung tissues, infection, and then, of course, problems that cause a diminished respiratory function or membrane of the actual alveoli and the structure of the lung tissue itself. So we're thinking of things like emphysema, chronic bronchitis, anything that causes interstitial thickening or scarring, fibrosis of the actual lung tissue itself. So that might even be asbestosis or, some long-term chronic lung disease that might cause a problem with the actual compliance of the lung tissue, so it doesn't spring back nicely, or the resistance. Yeah, so the actual alveoli themselves might have coalesced in something like emphysema. So all of those things can potentially cause an airway problem with the air getting actually through the lung and into the next thing, which is the ability to pump it around.
Right. And so as we're thinking about something like the airway, we could be asking, do you have a history of asthma? We could be listening for the wheezes and stuff. We could be, have you been a smoker? Have you been coughing lately? All that sort of stuff helps support the structure. And those are the signs that we'll talk about later. But those things, they tie together. While you're doing the questions, your partner's doing the exam, and hopefully it all kind of integrates.
It's nice to think of this being a structure that starts moving your questioning from the environment now through the airway and down through into the body. So that's a good way to remember it.
Yeah, because how do you remember all this, right? You got to have some sort of format.
Yeah.
So we've had the oxygen out here, we've had our brain suck it in, it's been able to go through the airway, it gets to that respiratory membrane, the space between the alveoli and the blood. Well, now there has to be blood there. They have to have, blood moving past to be able to pick up the oxygen that's coming in. So we start thinking about the heart, and is the heart working well? You can think about it. If someone's had a massive heart attack and their heart has stopped working, they may be able to move the oxygen. We could ventilate them, but it's not going to get around the body. So we start thinking about, obviously, acute coronary syndrome. Are they having a heart attack? Have they had heart failures? Are they in a dysrhythmia? If they're in a terrible VTAC or something like that, they may not be moving the blood. They may have mechanical problems inside the blood, like defects with the valves, and we can ask if they have a history of infection, if they've ever had, heart surgery, if they've ever been told they have a murmur. Those are the sorts of questions that we can ask about. We can ask about, there's some, weird shunts where the blood doesn't travel through properly because there's funny holes. So, for example, if there is a septal defect, the space between the atria or the wall between the ventricles, those walls, we naturally have a foramen ovale, a small space between the atria that closes up when infants are born, but sometimes it doesn't close up, and that's called a patent foramen ovale, or a PFO. There's also the ductus arteriosus that connects the aorta with the pulmonary artery. Usually we discover that in kids because they get a lot of deoxygenated blood circulating around their body. The tetralogy of Fallot kids, TET kids. So those things sometimes we'll see in young kids. It's a bit of a specialized area. There could be some mechanical compression of the heart. So you mentioned tension pneumothorax. We could have just hyperinflations of the lungs, which happens in really severe asthma, because asthma is a gas trapping. So you're really bad asthmatic who has massive JVD and a low blood pressure. It's because, their heart is getting squished between the two lungs that are overinflated. It could be a pericardial tamponade. It could be, all those sorts of things could lead to mechanical difficulties with the heart not being able to pump properly. And if it's not pumping properly, then we're not going to get blood going by. So you want to tell us a little bit about what should we think about blood?
Yeah, so when we think of blood, I think about the contents of the blood, like what is it actually made up of, and also what's actually getting into it. So I also think of it relating to perfusion, but we won't talk about cells yet. That's kind of a little bit later. But if you think of it related to perfusion, it's about the actual blood vessels themselves. It's about the blood circulating around, and it's about the actual fluid.
Yeah.
So when you think about the blood and its actual structure, you got to remember what carries the oxygen around. Okay, so remembering that it's the red blood cells and it's the hemoglobin that's carrying that little oxygen around. So if there isn't enough of that, and the person may be anemic or have some kind of problem with their actual blood count, then all a shape or the changes in the red blood cells, there's certain diseases that can affect it, then the ability of the blood to carry oxygen is another cause of hypoxia. So the blood itself can be an actual problem.
Sure.
Now, some of the other things that can happen is that, as you know, carbon monoxide is a real problem for us, because the monoxide loves to attach to hemoglobin way more than what oxygen does. So
250 or 260 times more. I can't remember the exact number, but like way
huge.
More. Yeah.
Yeah, and once it's there, it's hard to get off too.
Yeah.
So carbon monoxide is a problem, and that, when we put the pulse oximeters on, they don't read correctly because it's reading carbon monoxide instead of reading oxygen. So the person is actually hypoxic, but may present like they are actually with our SpO2 monitors. It might actually say that they've got plenty of oxygen, but they actually don't.
When I talk with my students, I tell them, don't call it an oxygen saturation monitor, call it a hemoglobin saturation monitor. Because it might be saturated with something other than oxygen. You pull somebody out of a house fire with oxygen saturations of 100%, that's not oxygen. That's carbon monoxide. They're hemoglobin saturated, but it's not with oxygen.
Yeah, that's exactly right. Yeah. So the other thing that might be a problem inside those blood vessels is that there may be clots. So, there could be a traumatic event. There could be a coagulopathy problem with the actual blood itself. The person might be bleeding out. There might not be enough blood.
That's right. There's no blood.
No, but other things like acidosis and alkalosis. So I always love teaching about the oxygen dissociation curve, but we won't talk about it in this. It's way out there. Yeah. But basically, It's a problem with getting oxygen on and then onto the blood or onto the hemoglobin. Then it's a problem with getting the blood also off. So in certain environments, alkaline and acidotic environments,
Hmm.
oxygen becomes hard to get to where it's meant to go just because of acidosis or alkalinosis in the blood. So those
Right.
are two other problems that we have.
Right.
And after the blood comes,
Well, we start thinking about the body because maybe there's some like systemic body effects that are causing people to have this dyspnea. I mean, the obvious one is, maybe they've just been running. Maybe they've
yeah,
just been really exerting
there's
themselves,
a
and this
reason
is
for it.
physiological and normal, and it's okay. It could be obesity. Obese people, especially when they lie down, will have the adipose on their abdomen push against the diaphragm, and it makes it difficult for us to excurse the diaphragm and actually breathe properly. It's something called, I don't know if you've ever heard the term Pickwickian syndrome. Have you heard that? There's
I
a
think yeah, maybe.
Yeah, I think Pickwick was a character in a Dickens novel, and he was an
Yeah.
obese man. He always had difficulty breathing. So they
Oh.
call it Pickwickian syndrome because, and there's a better name for it now, obesity-induced dyspnea, or something like that. I can't remember. But obesity makes it difficult to breathe, especially when supine. Pregnancy, of course, if you've got the gravid uterus sitting on the inferior vena cava, then it can reduce venous return. And of course, we don't get proper circulation then. And people can die from that. So, turning your pregnant patient slightly left lateral. So we take them off of the inferior vena cava, which runs to the right. Positional asphyxia, that's a big one where we're struggling with somebody. Maybe they're diabetic, maybe they were on psychostimulants, maybe they're CVA or whatever. And we
Mm.
wrestle and wrestle and wrestle with them. And we eventually get them, sort of held down so they're not beating us up, and we get a positional asphyxia where it's very difficult for them to breathe properly. And there are some rather famous cases where people have died from that. It's one of the reasons why paramedics prefer chemical sedation or chemical restraint as opposed to physical restraint, because then we can control their breathing. And then, of course, our body has to be able to move the muscles that cause respiration. So we start thinking about some of the rare type of motor neuromuscular problems. So myasthenia gravis, for example, which literally is like grave muscle weakness. So that's an autoimmune destruction of the acetylcholine receptors at the neuromuscular junction. Our body starts to eat up the receptors that stimulate us to move. And once they've been eaten up, we can't move very well. So people start to gradually become paralyzed. Guillain-Barré syndrome or Guillain-Barré syndrome is an autoimmune attack on our peripheral nervous system. So we start breaking down our sensory and motor nerves. Our body starts destroying our own nerves. And when we do that, we can't breathe properly. Amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. It's what, the famous scientist in the wheelchair.
Stephen Hawking?
Stephen Hawking. That's the disease that Stephen Hawking had and eventually
Really?
died from. Yeah. So he had ALS. And that's death of upper and motor neurons, and we don't exactly know why. So if our brain is working, we have to make sure that our brain is able to communicate with our muscles and get them to work, and that we don't have some sort of mechanical obstruction like obesity or pregnancy or positional asphyxia that's making it difficult for us to actually breathe. I remember doing a scenario once. It was an interdisciplinary training thing, and they gave us like a standard nursing scenario. We walked in, there's a guy in a nursing bed post-op, and he's having trouble, breathing. And I start going through all this pulmonary embolism for sure, and just doing all the fancy stuff. And the nurses go, just sit them up in bed. They're lying flat. Oh, right. Yeah. Okay. And then we set the patient up and they're like, oh, yeah, that's better. I can breathe. It's like, yeah.
You're like, why'd you make it so easy?
Yeah, I didn't even think of that, sit them up. And so, that's obviously important. And then once we've gone through that, we have to start thinking about,
Cells.
right.
Yes, that's right. So we've got it all the way down to where it needs to go, which is basically the end point and being in the cells. Now, the cells shouldn't usually be a problem, but there are problems that we encounter sometimes, not often, but there are certainly poisons and pesticides, weed killers, organophosphates, all
Yeah,
kinds of
yeah.
those kinds of, that family of things that we encounter, certainly that we do get called to. So things like arsenic and cyanide, paraquat poisoning.
Yeah,
I don't know if any of you
rare.
listeners, yes. Well, I was just thinking, I'm not sure if many of our listeners would know, but back in the old days, and I don't know if you've encountered it, but certainly paraquat poisoning was a contraindication for the delivery of oxygen.
That's right,
It was
because it
mentioned.
produces oxygen-free radicals, which are exacerbated by oxygen delivery.
That's it. So it speeds up the poisoning, speeds
Hmm.
up the whole paraquat poisoning. And I never understood that. I was like, paraquat? We've never seen paraquat. What is paraquat? But actually, it's a common component, or was a common component in weed killers.
That's right.
Yes.
Yeah,
And interestingly, I was reading about 93% of paraquat poisonings are from suicide attempts. So
that's
they're
right.
actual intentional.
It
Yeah.
has to be swallowed. You have to swallow, I think the rough rule of thumb is about two good mouthfuls of paraquat. It's not a topical poison. So usually these are people who are attempting suicide. And
Yeah.
there's often a lot of destruction to the air. This is part of one of the lectures we do in toxicology. And usually by the time you get to the point where you've got a short of breath paraquat patient, they're a dying paraquat patient.
Yeah.
You've
It's too
really
late by that
passed the
point.
threshold. Yeah.
Well,
Yeah.
cyanide's probably in the same category. You don't really come back from that with cyanide poisoning. It's histotoxic. So
Right.
it's histo being cell. In the actual cell itself, there's ATP, which is adenosine triphosphate, which is basically it's the cell's energy.
Hmm.
And it's the energy of the whole body, really.
Hmm.
But ATP is made by the cell, and product things like arsenic and cyanide, they interfere with the ATP production. And not only that, they also do horrible things to other things like potassium and other
Yeah, it's
important
complex.
other neurotransmitters and chemicals. So they do horrible things to those, but in particular, cyanide is actually really quick. It's a really quick poisoning. And its half-life, I think, is like 10 to 30 minutes. From memory, it's super, super quick.
That's
Whereas
long
with
enough to kill you,
arsenic,
though.
yes, well, that's it. Arsenic is not as quick, and there's different ways you can get poisoned with arsenic. It could
Hmm.
be environmental, and I think most of the poisonings from arsenic are in third world countries, and it's a byproduct of actually a lot of sort of industry problems that aren't looked after environmentally particularly well.
Yeah.
And so people get slow, long-term arsenic poisoning and lead poisoning and other poisonings like that. So it is nasty stuff, and it does cause problems with increased lactate production and things like that in the body,
Yeah.
and also hydrogen peroxide, would you believe? So the body starts manufacturing inside itself things like lactate and hydrogen
Oh, wow. I
peroxide as
didn't
a
realize that.
byproduct of the metabolism. So yeah, so nasty, and at the cellular level, you can just imagine all that stuff's going on. You're not making energy, and you're getting all these horrible byproducts that
Right.
interfere with the normal cellular function.
Right.
And obviously, oxygen consumption is not happening as the way that is meant to.
Yeah, it interferes with cellular respiration, the actual
Yes.
recharging. Now, I'm not sure if it's still true, but I know that at one time the black PVC pipes that,
Yeah.
take the water away from your sink or something like that. My understanding was that when they burn, they can produce arsenic. And that's why house fires are so dangerous. You see people standing outside watching the fire and the smoke comes and they're all, with this, and you're like, get out of the smoke. There's
Yeah.
carbon monoxide in there. There's arsenic in there. Don't
Yeah.
go near something that's burning. Like when buildings burn, it's dangerous and
Oh,
terrible
yeah.
stuff comes out of there.
Yeah, I've been in responded to a few major fires. We had the Canberra bushfires,
Oh yeah.
and the sky was like night, and
Ooh.
yeah, it was awful, and everyone was wearing face masks the whole time
Yeah.
because of that. We had a massive one in New Zealand where a few fireys died, actually.
Oh,
Same thing
tragic.
again. We went past it, we just drove past it. We weren't actually attending the job, and it was again black. The
Yeah.
sky is black. You've just got to think of all that particulate matter floating around in the sky that everyone's inhaling.
Yeah, you don't want to breathe that stuff in. So, of course, when we're doing our assessment of the patient, we can ask about things like that. Have you been around anything that's burning? Have you been in another country, particularly third world country, drinking untreated water? Like
Yeah.
that's how the idea of this gas flow review is to focus our questionings to see if I wonder if any of this stuff might have happened.
Mm.
And that's really, we're talking in some ways, getting into a little bit about signs versus symptoms. So the sign is something that you can see, whereas a symptom is something that a patient reports. So we're trying to elicit those symptoms from them through our questioning. And at the same time, we can switch over now in the podcast to let's start doing our actual physical exam. So the assessment consists of the interview, where we're thinking about symptoms, and the physical exam, where we're looking for signs. And I've come up with kind of this weird thing, because this is the way my brain works, of organizing them like from A all the way down to U. And I've actually been building this over a few years. And I was talking to a student a little while ago, and they said, "Oh, when I first heard this, you were only up to K." It's like, I know, I'm just looking for the last few letters. But when you actually use this system, it works really well. And we're not going to assess all of these in every single patient, but it is a good sort of mental mnemonic for you to be able to use. And it's easily memorized with just a little bit of practice. So let's start going from A, B, C, D, E, all the way down to U. And I'll leave the A with you, Sonia.
Okay, so A is accessory muscle use. And you've only got to think of if you could have a patient in front of you and you're looking at what the normal muscles are for breathing.
Right.
When I'm sitting here, actually, and this is probably why taking a respirator is the most cheated on.
Yeah, I know, we're terrible at it.
It's actually really hard
Not
to
just
see.
paramedics. Yeah.
It's really hard to see me breathing.
Yeah.
You can't really see me breathing at all, can you?
No, I can't. You're so sneaky breather.
I am a sneaky breather. So to use accessory muscles to it's a passive process, breathing out. Breathing in takes, muscle expansion, and the ribs and the intercostals all expand. In an adult, you'll see my chest move. In a child, the chest doesn't really move. It's usually my abdomen that moves if I'm a child.
Because they're diaphragms.
So there's so you'll have a couple of little differences depending on how big you are.
Mm-hmm.
But it's a pretty passive process. It's that important for life. We don't use a lot of muscle. And then when you start getting into respiratory distress, you start picking up different other sets of muscle.
Yeah, your whole chest starts working.
That's it. And there's so many other muscles that we can start adding in. Everything from in the muscles in here, the sternal,
sternocleidomastoids.
Yeah, the cladomastoids and the suprasternal muscles.
Yeah.
And you'll see recession and drawing in and sucking in. This is why it's really important to expose the chest and actually have a look.
Yeah.
And you'll actually see on a really good respiratory distress, you'll see this area between the ribs being sucked in on children.
Pulled in.
And it's quite impactful. Look at you, it's like, wow.
Yeah.
And then on children, you get as well the seesaw breathing. So instead of being that just the abdo, you'll actually get this chest and abdo happening.
Right.
So what we call a seesawing.
Right. So the chest expands and the abdo goes down, then the abdo expands and the chest goes down. Yeah.
Which is abnormal for a child. Normally, it's completely different and a little bit different to what an adult is. So it's good to know the difference. All right, so after accessory, A comes B, which is?
So B is breath sounds. And when we're talking about breath sounds, we're usually talking about listening with a stethoscope. And I think breath sounds aren't covered very well typically in medical education. I've even seen this with doctors. A lot of doctors say, you have to learn those yourself. So I've come up with a way of thinking about breath sounds that has 4 components to it. The first component is the actual sound itself, and we call that the adventitia. So wheezes, crackles, all that sort of stuff is adventitia, or bad sounds. And then when I say you report, for example, the patient is wheezing, that's insufficient. I want to know more. I want to know about that wheezing in 3 different planes. So on an X, Y, and Z axis. And for me, I want to know about the top to the bottom of the lungs. So how high and low in the lungs does that adventitia exist in? Do they have crackles all throughout their lungs, apices to bases, or do they just have basilar crackles? I also want to know about left versus right. Crackles in one lung is very different than crackles in both lungs. That tells me something very different. And I also want to know about the phase. And when I talk about phase, I'm talking about inspiratory versus expiratory. So inspiratory wheezes are concerning. Inspiratory and expiratory wheezes are more concerning. So let's go through those in a little bit more detail. And the first one I'm going to talk about are breath sounds. So normal breath sounds, the fancy term for that are normal bronchovesicular breath sounds. And that's the sound of nice, smooth airflow through the airways, what we call laminar airflow. And that's what most people should be like. If you think of, just type of a heavy breathing sort of thing, those would be called normal bronchovesicular breath sounds. And then sometimes we have wheezes, and most people are familiar with wheezes because like everybody's got asthma, or they know somebody who has asthma, or they've had exercise-induced wheezing. It's that high-pitched whistly noise, and that's created by airflow sort of whistling through the constricted small airways, and therefore you get that high-pitched sound because it's a very small airway. I don't know if you had these in Australia, but in Canada when I was a kid, we used to have these big soft plastic tubes about a meter long, and you'd hold one end and you'd swing it and they'd go,
Yeah, yeah,
woo. That's a wheeze.
yeah.
That's a wheeze. But if you had a teeny little tiny straw going, that would be what a wheeze sounds like in a human. So wheezes, there's a saying that we have that not all that are wheezes are asthma. So there's other causes of wheezes as well. We think about asthma, we think about COPD, it could be early pulmonary edema, it could be allergies or a toxic reaction, it could be airway burns. There's a lot of things that can cause wheezes. So normal bronchovesicular wheezes, crackles are a bubbly sort of crackly noise, hence crackles, sometimes called rails. And that's created by fluid inside and around the alveoli that's making a bit of a popping sound as they open from the inspiration. And that's usually due to pulmonary edema. We have, next one is rhonchi, which are coarse. They're like low-pitched, wheezy, like a snoring noise. And honestly, the best way to do this is go onto Google and listen for some MP3s of these different sounds and get used to them. I sometimes describe rhonchi as kind of a cross between crackles and wheezes. And in Australia, I've heard it called tradie lung. So like a tradesperson gets these tradie lungs because they're often due to long-term exposure to irritants, usually smoking. But it could be pneumonia, chronic bronchitis, cystic fibrosis, COPD. A lot of those, of course, are caused by smoking too. One of the things you'll find about rhonchi is that you'll listen to someone and you'll hear this sort of a sound as they're breathing in. Take your stethoscope off, ask them to cough, put it back on the same point, and you'll notice it might have changed a little bit because it's gunky, and sometimes they can change markedly after a cough, and that helps identify it as rhonchi. Stridor is another form of adventitia, and that happens usually up in the upper airway, up in the larynx. So it's a high-pitched squeal coming from the trachea. It's one of the few adventitious noises that we can make without actually having them. We can fake it, so like that sort of a squealy type of noise. Usually I cough when I do that. That would be described as a stridor, and that's what we hear in airway burns and anaphylaxis and croup and epiglottitis, and those sort of upper airway constrictive diseases, and or foreign body airway obstruction with partial passage, right? And the last one we'll hear sometimes are rubs, which is, as it sounds, like a low, dull rubbing sound. And that, oops, hit my microphone. That's caused by, there we go. That's caused by the visceral and parietal pleura of the lungs not moving over each other smoothly. So you hear a bit of as people are breathing. It's rather rare, usually due to infections, usually pleuritis or something like that. So if you hear some of those sounds, wheezes, crackles, and rubs, like I said, I want to know about height. So if it's just at the bottom, we call that basilar. If it goes up halfway, we say it's about mid-scapulary, and if it goes to the top of the lungs, it's up to the apices. So I might hear pulmonary edema from apices to bases, I might say. And then I want to compare left and right. So I'd say pulmonary edema bilaterally from the apices to bases. And then I want to know about the phase, which is inspiratory, expiratory, or both. So I might say they have bilateral inspiratory, expiratory wheezes, apices to bases. So I've included the adventitia, the height, the left versus right, the symmetry, and the phase. And you've got to include all four of those in your auscultation report. So that's breath sounds.
That's
a lot
good.
to it. Yeah.
Yeah. Thanks, Mark. So we're going to move on to C, which is condition of skin. I like the way how you snuck the C in there for skin.
Some of these I kind of had to squeeze them in.
All right. So the condition of skin, as you already probably know, the skin is everything, and everything to do with oxygen, isn't it? The skin is usually the first thing that tends to change when someone's unwell. They go pale, the color goes off. with hypoxia, we usually get, bluish tinges and things like that. You
Yeah.
might get bluish tinges on the tips of their nose or on their
Mm-hmm.
lips. You might get peripheral discoloration, especially on children. You'll get peripheral bluish tinges to their fingers. Long-term COPD patients and stuff, sometimes that might just be their normal way that they look, is just this constant little bit of cyanosis on the skin. And it might even look a bit a grayish kind of tinge
Yeah.
sometimes with the blonde.
Smokers. Yeah.
Yeah, with the blue tinge to the lips and to the nose. Or
And you
even
can ask the patient, right?
fingers.
You can say, is this the normal color of your skin? If they go, oh my God, no. It's like, oh, all
Yeah,
right.
yeah. Give them a mirror.
That's right.
Yeah, so they do get that funny kind of ashen or bluish tinge, and on the little peripheries of the ears and the nose and the lips and the fingertips. Yeah,
Distally, yeah.
yeah, that's right. Now, temperature, you might find that their temperature goes off too. So the person's temperature may be high because they have a fever, and so they have a hypoxic process going on because they're burning a lot of oxygen.
Mm-hmm.
Conversely, it might be the opposite. So you might have a hypothermic person who's not using oxygen because they don't really need it because the body's shut down.
Right.
So now skin turgor. Turgor is the actual elasticity and the rebound of the skin. So when someone is dehydrated or they don't have good skin turgor, it could be because they're a bit older too and they've lost the elasticity. We tend to dry out as we get older, and the elderly patients tend to lose skin turgor too.
You get leathery.
Yeah, they get
Yeah.
leathery and you lose that elasticity and spring of the skin. So dehydration, any kind of signs to do with that skin is a really good way of assessing. Even without really touching, you can kind of get a good look at the skin and see whether there's changes in relation to the respiratory patient quite easily.
And really important too with any patients who's tachypnic, because if they've been tachypnic for a while, we exhale water vapor. And people don't think of this, but if you're really bad asthmatic and you've been hyperventilating for a while, well, it's not technically hyperventilating, but tachypnic for a while, you can be blowing off a lot of your fluid, like blowing off your water and be dehydrated.
Yeah, good point.
Yeah.
Okay.
I love that you say turgor,
Turgor?
where I would say turgor, skin
Well,
turgor.
did you notice you say tachypnic? We would say tachypneic.
Tachypneic. Okay. Yeah. Tomato.
Yeah. So what do you say, turgor?
Turgor.
Turgor.
You got to get the turgor. Skin
Turgor.
turgor.
I'm surprised that we don't say it like that more.
Yeah.
I bet you in some areas they do.
Probably.
Yeah.
Probably.
All right. So we move on to D.
Yeah. And sweating. Don't forget about sweating with the condition of the skin, the diaphoresis.
Oh, diaphoresis.
Yeah.
Absolutely.
Because
Goes in.
obviously if you're sweating, you're losing a lot of fluid as well.
Same thing. Yeah.
So D is for dyspnea, which is obviously a general term, but in this case, we use it specifically to mean word dyspnea. And word dyspnea is the number of words that you can get out with just one breath. So, for example, if I were to take one breath and then start talking to you, then I could probably get about 25 words. That's 25 words. So, above 10 is pretty normal. And you can actually, I do this with my patients, my students, when I'm doing a class, I say, imagine if all I can do is get one or maybe two words out per breath, like I do nothing else, it automatically sounds like I'm short of breath. So just by doing that, just by speaking with only one or two or three words per breath, it already automatically sounds like you're short of breath. So it's a really useful tool. I think word dyspnea is the best global measurement of your respiratory status. If you're getting more than 10 words per breath, then you're doing okay. And one of the things that I'll ask patients to do when I'm working in the field is say, I'd just like you to take a normal breath in and then count to 10. And if they go, 1, 2, 3, 4, 5, 6, it's like, oh boy, that's like 2 or 3 word dyspnea. And if somebody tells me that, if I'm backing up another crew and they say, they've got like 5 word dyspnea, yikes. So that's a really good global indicator.
Yeah, and you can use it on your patient report form too and handover, can't you?
Oh yeah, if I'm updating to a hospital, I say, look, they're getting 3 words out per breath because they might not know the term word dyspnea. But if I say they're getting, 3 words per breath, any experienced clinician is going to go, yikes.
Yeah, they'll know.
Yeah.
Yeah. All right. So E is for extending position.
Right.
And in this, we'd like to talk about the patient and the way that they position themselves to quite often either open up their chest or put them into a position that is easier for them to breathe. And you'll know this is tripoding, which is the most commonest term that we use to describe somebody. And what it is that their body is one point of the triangle and their arms are the other two, and they'll sit forward. And what this tends to do is hang that thoracic space, and with the least amount of energy use, it actually provides extension of the diaphragm and extension of the lung cavity. So it makes it easier for them with less work to breathe. So tripoding is, when you see people tripoding, you know that they're in respiratory distress. You know that that's a common patient position, whether it's asthma or emphysema. It doesn't really matter what it is. You'll do it when you've been for a run.
That's right.
You put your head over and you put your hands on your knees.
Or you put them up against the wall, right?
Yeah.
Same thing.
Yeah.
Because actually the tripoding ties in really well with the accessory muscle use, because when you're using those extra skeletal muscles for the breathing, if you brace your hands, then they've got a firm base to move against. Whereas if your hands are, hanging at your side, you don't have that. Like if you just do it, if you're listening, don't do this if you're driving. But, if you've got your hands on the table or hands on the steering wheel and you sort of brace yourself, you can feel that your chest muscles have something to push against if you've tripoded your arms and secured them. So you'll see people do that after a run, right? What happens? People go for a run, they lean over, they put their hands on their knees and they go, and they tripod, and it allows their skeletal muscles to become involved with that respiratory motion.
It is. It's a much more comfortable position than any other position. So, and rather, I can't imagine laying down being short of breath or any other position. Yeah. Tripoding it's natural, and you can place people in that position.
Yeah.
I have actually patients that I've had in the back of the vehicle, and I've tried to actually sit them up. I had one COPD patient, which I remember specifically. He wouldn't lay on the bed, but he would sit on the side of the bed in a position on the way to the hospital. So I ended up sitting on the seat.
Yeah, it's always a little dangerous, but you got to do it. I've done that too, especially people with a lot of pulmonary edema and stuff. Okay, so A is accessory muscle use, B is breath sounds, C is the condition of their skin, D is word dyspnea, E is the extending position, F is the finger probe. And that's the what I'm going to call the hemoglobin saturation monitor. And of course, it's an obvious one that we look for. Skin used to be what we looked for first. There's the poor man's SpO2, but now we look for the oxygen sat. And I like clinically to do that as one of the first things I do when I encounter the patient, because I want to know their sats on room air, and then get an idea of how that changes once I've put the oxygen on. So that measures the gas coming in.
Good. Okay. And then the other one is G, and we're talking about gas values in general here. And the other tool that we've got, which I think is more of the gold standard for measuring oxygenation, is capnography.
If I had one measurement, it would be end-tidal CO2. Yeah,
absolutely. Yeah. Well, for respiratory patients, capnography does everything, doesn't it? So, so capnography is two things. It's the numbers, the actual number value,
but
it's
also capnometry.
Exactly. That's the capnometer, I want to say. It's the number value out of 100. And then you've also got the actual waveform itself, which is the wave capnography, being a graph.
Right.
So having an understanding of the different shapes of the waves is probably the most important thing when you start moving into capnography.
That's a whole other lecture.
It is. And, everything from, you can see bronchospasm because of the shark fin shape.
That's right.
You can see obstruction because of the change in the wave. So a capnography meter.
Capnograph.
I want to try and make it easy first. But it'll have numbers and it'll also have a waveform. That's so you can't really have one without the other. You need the two.
Yeah, it's more useful.
I have seen in some places they'll just have a capnometer.
Yeah.
And I don't think that that's good enough. It's meant to be, the gold standard for, endotracheal tube placement now.
Yeah, absolutely.
We're not meant to place tubes without capnography now, but quite often the services have gotten around it by just having a capnometer, which I don't think is good enough.
No, I wouldn't be comfortable with that either.
No, you've got
Yeah.
to have the actual waveform that goes with it because, especially with having a tube down someone's throat, you can
Sure.
actually see when it's in the wrong place
Yeah.
by the actual shape of the wave itself. So,
Yeah.
extremely important. And yeah, one vital sign that we don't do enough of is, capnography.
Right. And you'll remember that when we did our secondary survey and we talked about the vital signs, we said that there's a dozen of them. And one of them is end tidal CO2.
Yeah,
That's something that you should be looking at every time.
yeah.
Okay, next one, obvious one is heart rate. Obviously, when people are having trouble breathing, their heart rate will go up. So with tachypnea, normally comes tachycardia. But if you have a tachypnic patient who's bradycardic, you should be scratching your head over that one and wondering what exactly might be going on with them. Maybe there's cardiac problems or something and beta blocked, but don't know.
Yeah.
But yeah, make sure you get the heart rate because that's a useful tool when we're considering the overall picture of our respiratory patient.
Mm. Now, the next one is interesting. So, without even, thinking too much about it,
Yeah,
take a breath in and then release. Now, how long do you think the time it takes compared to breathing in to breathing out?
I know, I know. I would say in a normal patient, it's about 1 unit of time for breathing in and about 2 units of time roughly for breathing out. So it's a 1 to 2 inspiratory expiratory ratio.
Very good.
There you go.
Now, if you've done a lecture on capnography, you'll actually see that in the respiratory cycle as well.
Mm-hmm.
Yeah. So you have this inspiratory phase and then a bit of a pause. And that's, when the oxygen has been exchanged and then, it plateaus along and then it drops off.
Right.
So the actual time that it takes, and don't forget, breathing out is a passive process without respiratory disease. So long as I don't have, some pulmonary asbestosis or something like that,
Right.
the actual process of breathing out is passive. It's just the muscles relaxing expels the air.
So it takes
Okay.
longer. Yeah.
That's it. It takes a lot longer to breathe out than it does, which is the active process of breathing in. So when you think about things that can go wrong inside the chest, so say asthma, which is a problem with air trapping,
Right.
okay, so the air gets stuck in there and it can't get out,
Right.
you have things what we call a prolonged expiratory phase. So I might have to actively try and blow the air out of my lungs by squeezing my chest and maybe pursing my lips and causing
Right.
myself to, try and get some pressure to try and breathe the air out.
Right.
So you can have problems with getting the air out due to a compliance or resistance problem in the lungs or things like asthma. So yeah, so think about things like pneumothorax and asthma, COPD. They all affect that inspiratory, expiratory time,
Yeah.
the
And
ratio.
if you think about this, like if you're an experienced paramedic and you've seen patients, I'm going to do some heavy breathing for you.
Go.
An asthmatic would sound something like, they've got that prolonged, like it could be a 1 to 3, 1 to 4. Whereas if you've got the COPDers, they often have a prolonged inspiratory time. So it sounds something like, and you get that prolonged inspiratory. So it's one of those things where if you're an experienced paramedic, you walk in and you just hear that IE ratio and go, oh boy, okay.
And of course, don't forget, we also, I don't know if you guys still do it in Queensland, but we used to do chest thrusts or chest compressions. We used to help people breathe
Right.
out in asthma. So we used to, they breathe in and then we'd get on the side of their chest and help them squeeze the air
Active
out.
chest compression. Yeah.
Yeah.
It's one of the papers I want to write because I've got a bunch of papers on that. And the short and sharp of it is that you really shouldn't do it unless they're an extremis. And if their blood pressure starts to drop, then you should decease? No, not decease.
Desist.
Desist. Is that the word?
Yeah, desist.
Okay.
Resist. Yeah.
You should
Stop.
stop. Stop squeezing if their blood pressure drops because you're squishing their heart too much and it's occluding the flow. Okay.
Well, also barotrauma is our other issue, isn't it?
It can be, yeah, but usually these people are already dying, which is why we wait until the end. But
Yeah.
wait for it. One day when we're done the APCPGs, I'll do a paper on that, or if I get a keen student. If anybody's
It's
listening
true.
and really wants to do it, I'll co-author with you.
Honors project.
Yeah, there you go. Okay, so what are we up to? That was
We're up to
I
J.
for IE. So we're to J, which is jugular venous distension. So as we walk in, we can usually see people's JVD. And if they're sitting up and their JVD is up to the angle of their jaw, we got to think, why can't their blood get into the heart? So something is occluding the heart. Usually in a respiratory patient, it's hyperinflated lungs, which are compressing the heart so they can't properly fill. Or you can think about it, things like, what do you have? Asthma, obviously, cardiac tamponade, tension pneumothorax, right-sided heart failure, right ventricular infarct. All those things will make it difficult for the blood to get in. The analogy I use is if you go to a club and there's a big lineup along the sidewalk, it means people aren't getting in. So if you see somebody with massive JVD while they're sitting up, they shouldn't have JVD, it should only be about a finger or so above the clavicle, then that means the blood's not getting in. There's a lineup on the sidewalk, blood can't get into the heart. Why would that be? And of course, if the blood can't get in, it can't get out. And if it can't get out, they're going to be short of breath because they're not perfusing properly. So, asthma, emphysema, bronchitis, diseases of hyperinflation are other things that will cause problems with the JVD. Then we get into K. K's fancy. K's got a lot to it because we're talking about patterns.
Well, that's it. So K for Kussmaul's.
Yeah.
Do you pronounce it Kussmaul's? Just checking. Yeah, Kussmaul's.
Kussmaul's,
yeah.
as I'd say.
Say Kussmaul's.
Kussmaul. Good day, Mr. Kussmaul.
That's it. So we're going to talk about the ABC of Kussmaul's. So, in the sense of it's a respiratory pattern. So each one of these letters will stand for something. So K meaning ketosis.
Yep.
So think about diabetic ketoacidosis.
Well, let's say what Kussmaul's is first. Like, what's the pattern that we're looking at? Yeah.
Sorry, Kussmaul's breathing. So have you seen Kussmaul's breathing?
I have.
I have.
Yeah.
I have seen Kussmaul's breathing. So
any DKA patient will.
Yeah, that's it. And look, once you've seen it, it's actually, I don't think you'll ever forget it because it's really quite interesting to watch.
It's labored. Yeah.
Yeah, it is. It's such a heavy, I just want to do the breathing and try and replicate it. What they're doing is they're like blowing off extra acidosis in the blood. So they have a metabolic acidosis, which they're trying to convert into, I'm feeling a bit lightheaded now, into a respiratory acidosis. So you can change your metabolic and convert it into respiratory, blow off the extra carbon dioxide, which is blowing off acid, which then reverts that, flows backwards and hopefully reverts some of that metabolic acidosis and makes it a bit more stable. Yeah. So the body has a way of trying to get rid of metabolic acidosis by initiating this deep, heavy breathing.
Respiratory alkalosis.
Exactly, which is trying to counterbalance the metabolic acidosis.
Right.
So it's pretty ingenious kind of thing that the body can try and do. But anyone who's in an acidotic state will have this heavy respiratory pattern, which is they're trying to create that alkalosis.
That hyperpnea, the deep breaths, and the bradypnea. It's not like, it's like
deep, heavy breathing.
Full vital capacity breaths. Yeah.
Yeah, absolutely.
Okay. So causes. Now we'll talk about causes.
All right, now we're going to talk about causes and go into the actual, the name, the letters, sorry. So K being ketosis, which we've already spoken about. U being uremia. So uremia is a problem with proteins in the urine. So start thinking kidney problems, kidney issues, renal dialysis patients, those kind of things.
And the kidneys are buffers, so they get into a metabolic acidosis because the kidneys can't buffer.
Yeah, the one place in the body where you're trying to, regulate bicarbonate and all of the other, things that are produced that actually try and regulate acidosis.
Right.
S for salicylic poisoning, so aspirin, which we already talked about.
Causes metabolic acidosis again.
Yeah, metabolic acidosis. M being methanol poisoning, so industrial solvents. Now, I don't think I've come across that. I've come across well, what about, is methylated spirits related or not? So methanol being, or is it? Yeah,
methanol is, it's when people used to do moonshine and stuff like that. They were trying to produce ethanol, which is the normal alcohol that we would use. I don't know enough about the chemistry, but
it's the first one.
It's
it goes
form
meth and F.
Does it? Okay.
Yeah.
So it's not properly made yet to be safe for us.
Yeah, distilled or whatever the bloody process is.
A lot of the industrial solvents will have the methanol in it.
Which makes me think of it being like a methyl spirit rather than an alcohol. Yeah,
I don't know enough. Well, technically it is an alcohol.
Yeah, well, I've seen people drink meths, like methylated spirits, and I've seen the results of that. And I've got a feeling it could be something similar to that.
Yeah, it probably is.
Yeah, antifreeze poisoning. So Cosmal A, antifreeze,
Yeah,
ethylene, which
yeah.
is, it's one of those common spirits that we've got also that we use. Don't forget, antifreeze actually tastes
Sweet.
okay.
Yeah.
Yeah, which is the scary thing
Kids will
about it.
get into it.
We used to see a lot of animals when I was
Oh,
doing
right. Yeah,
vet
sure.
work come in, dogs drinking, antifreeze, which is pretty horrible.
Oops. Yeah.
Unavailable bicarbonate, diarrhea, small bowel resection. So when you think about someone who doesn't have enough bowel to regulate the normal amount of fluid uptake, which is
Hmm.
the bowel's, primary function is to reabsorb anything left over in there, all the goodies.
Right. The large
So
intestine. Yeah.
yeah, the large intestine. So if you start thinking that you've had something happen to your bowel or whether you've got a problem with it at the moment, so you've got diarrhea, so it's not passing, it's not absorbing as it should,
Hmm.
then you're going to start missing and getting that balance upset in the body of the normal fluid and bicarbonate
Right.
processes. L is the last one, being for lactic acidosis.
Right.
So, for whatever reason, you've got a lactate acidosis, and it could be a buildup, could even be from trauma.
Yeah.
So, lactate is an important product, but it is a byproduct also in the body because of other things that happen.
Right.
So, even things like sepsis, infection, and stuff like that.
So Kussmaul's is actually eponymous. It's the name of the guy who originally identified this, but some clever med student somewhere, I'm assuming, or maybe a nurse, maybe a paramedic, I don't know, but probably med student, came up with this mnemonic of Kusmaul. Kussmaul's has actually got two S's, the guy's name, but they came up with
Cheated.
that clever. What's that? They
They
cheated a bit.
cheated.
That's right. They could have put another S in for something else.
You would have done that.
I would have. Don't forget other things. But it's a great mnemonic for remembering
Yeah.
Kussmaul's. And that's the first bizarre sort of abnormal respiratory pattern.
Good. Okay. So the next one, which is also a part of this, which is another pattern,
Hmm.
is that another ABC, and it's we want to talk about A being apneustic.
Yeah.
So apneustic being prolonged inspiratory, and shortened expiratory.
Yeah.
So we just gave an example of that. You would
Yeah.
like to do another one again, wouldn't you, Mark?
Oh, I'm dying to.
Okay.
So it's,
Show us an example.
and then there's that pause.
All right. So that is the complete opposite of what is normal.
Yeah.
Okay.
Yeah,
So
we've
what is
inverted
normal?
the IE ratio.
That's it. Yeah, we've
Yeah.
had a complete. And again, so we're thinking about things like COPD
Hmm.
and those kind of resistance and compliance issues with the lungs that people have to alter what would be a normal passive or active process of the breathing in and passive breathing out.
Hmm.
Okay, agonal breathing. This is something that we see usually in patients who are on their last breaths.
Death breath. Yeah.
Yeah, last breaths, unfortunately. So agonal breathing, again, it's one of those things that once you see it, it's you really notice it. And also the breathing that goes, I would say, along with head injuries, I quite find sometimes is agonal as well,
Yeah.
depending
Could
on what stage that
Yeah.
they're in. So it's an irregular, labored, inefficient gasping.
be. Right.
So quite often we would arrive at a cardiac arrest and you would see this,
Yeah.
and you do we call it the like fish
The
mouth.
fish out of water. Yeah. We describe it
Yeah.
that way. Yeah.
Yeah. So it's like
Yeah.
it's not, and it doesn't usually, it's an ineffective. They don't even sound like sometimes they're actually inhaling properly. It's almost like a spasming of the respiratory tract and a spasming of the functions of the tract to take a breath.
Yeah.
But sometimes it doesn't actually happen. Like the breath itself doesn't actually really happen properly.
Yeah.
Biots. Do you pronounce it biots?
Biots, I would say. Yeah.
Yeah, biots. Yep. Okay. So remember, it's AAB,
Yeah.
biots.
So apneustic, agonal, and then biots. AAB. Yeah.
Yeah. So which is
Yeah.
tachypnea or hypoapnea. So I say,
tachypnea with hypopnea. So fast but shallow. This is basically panting. Biots is
yeah,
panting.
yeah, that's the best way of explaining it. Yeah. Fast, shallow, like a dog.
Yeah.
Yeah. Yeah. So biots is like a dog. If you remember biots, dog-like,
Yeah.
panting.
Yeah. That's how I remember it. Biots is panting.
Yeah, and it's quite easy to, if you artificially do this to yourself, and I've done this with playing with capnography, ETCO2 with students,
Oh,
it's quite easy to hyperventilate.
yeah. You blow off your CO2. Yeah.
That's it. Yeah, it's the quickest way of reducing those numbers is do panting breathing.
Yeah.
Yeah. Okay, so let's talk about C, which is now chain stokes.
Right.
Again, it's a very noticeable pattern of breathing. Once you see it, it's a very, remembering, you can remember the
Memorable.
style of
Yeah.
breathing. And it's the crescendo, big breathing in, and descendo within a pause of
Yeah.
apnea.
I think of this as the torsade de pointe of breathing. So you'll hear people going,
Oh, oh, that's a nice way of saying it.
it's torsades pattern, right?
Yeah,
So you see them build up to this crescendo build, and then the descendo or diminuendo, and then there's an
yeah,
apneic pause, like in torsades,
yes,
and then it
yes,
starts a,
yeah. And in a
then it
cardiac
goes.
arrest, I must say that I've come across patients that they'll have a period of apnea for maybe even 10 minutes
Yeah, yeah,
and then they'll come back. So that there's no, I would say, firm pattern with chain stokes. You may find that someone might do chain stoking for a minute, or they might continue doing chain stokes. So it's nothing that is a continuous type regular pattern. It can change throughout an arrest.
yeah.
Someone may initiate chain stoking breathing. You may think that they're getting better, and then it goes away again, and then you've lost them again for the
Yeah.
next 10, 20 minutes.
Or you can
So it
see it
is
in neuro patients who are alive. Sometimes you'll see that classic
brain
chain
injury
stokes pattern.
patient.
Yeah.
Yeah, brain injuries again. So we're talking really sick patients when we're talking chain stoking.
Yeah, in any of these, when you start to see Kussmaul's, apneustic, agonal, biots, or chain stokes, it's like, ugh. Like report that, and the emerge will go, uh-oh.
Yeah. Oh yeah. They'll know that something serious is on its way.
That's right.
Yeah. And so hand in hand with that goes the L, which is
Yeah,
level of awareness.
right. So Kussmaul's was, the K was kind of complicated because it was Kussmaul's, which really stood for patterns. And the
Yeah.
patterns were Kussmaul's and the other four, the ABCs. Then we go to levels of awareness. Probably one of the most sensitive indicators of hypoxemia. When people are hypoxic, their levels of awareness change very quickly. But there are lots of other things that can change levels of awareness. So if somebody is short of breath and they've got diminished levels of awareness, then yeah, then I start to think that the altered levels of awareness are because of the difficulty with breathing. Now, interestingly, most people think that if someone is profoundly short of breath and they have altered levels of awareness, it's because of the hypoxia, it's because of the low levels of oxygen. But usually it isn't. Usually, the reason why people are having decreased levels of awareness is because of the hypercarbia or hypercapnia, whatever you prefer. They've got high levels of carbon dioxide. And when carbon dioxide is retained in the body and our blood is filled with carbon dioxide, it actually acts kind of like a narcotic on our central nervous system. We call that CO2 narcosis. So when you walk into the asthmatic who's gas trapping and can't exhale their CO2 and they're, the sleepy asthmatic. The sleepy asthmatic is a dying asthmatic, right? We say that. So when you see the
Mm-hmm.
sleepy asthmatic, the rookie tendency is to think, oh, they're hypoxic. It's low oxygen. I've got to bag them up. Get the bag valve mask and punch a whole bunch of oxygen in. But it's not. The problem is that they're holding on to their CO2 and they're in CO2 narcosis. So instead of having your instinct be blow more oxygen in, your instinct should be, let me get the salbutamol and the ipratropium bromide and some steroids in them so we can open up their lungs and actually get the gas out. So
Out.
hypercarbia is really the issue. And that's, we talk about type 1 respiratory versus type 2 respiratory failure. Type 1 respiratory failure is the hypoxia. Type 2 respiratory failure is the hypoxia plus hypercarbia. So whenever you see somebody with dyspnea with altered levels of awareness, think not hypoxia, think hypercarbia. And that's L,
That's
levels
it.
of awareness.
And that actually relates to those things about, well, is it an issue with the actual levels of oxygen in the environment, or is
Right,
it a problem with obstruction and the way that the person is breathing,
right.
isn't it?
Yeah.
Okay, good. All right, so after L comes M, and
M.
we're going to use it for midline trachea. So the trachea
The trachea?
is yeah, you said trachea. We
We say
said
trachea.
trachea.
Yeah.
We do say trachea. We like to drag out some things.
Yeah.
So the trachea,
Right.
is actually in the middle of the throat in here, runs down the center. Now, when we're looking for a midline trachea, we're meant to palpate it. We're not just meant
Yeah.
to visualize it. You want to actually feel that it's midline.
Right.
Now, when it's not midline, the trachea is connected to the lungs.
Hmm.
So it could be a problem with some kind of trauma actually to the area itself, or it may be that there's a trauma or a problem in one lung or the other, and it's moving the air and the spaces inside the chest cavity one side or the other. So, for instance, there could be a pneumothorax or a tension pneumothorax,
Hmm.
and the air in that side has expanded and it's pushed the lung over and pushed the trachea to the side.
Hmm.
So you'll get a midline shift. Now, you need to palpate it because you can't often always see it. And
Yeah.
quite often, the last thing to happen is the actual trachea to move. So you've actually got the pneumothorax happening, but this hasn't even changed yet.
Oops. I got a quick story about this. Is I did a call once for a guy who was a rodeo bull rider, and he got
Oh,
thrown off of the bull, and the bull stomped on his chest. And when you actually saw his chest, you realize just how massive these animals are, because it was a horseshoe that basically took up his entire chest. And
wow.
it was really a big smash. And I thought, this guy's going to tension. And sure enough, he started developing shortness of breath. He started to get JVD. His blood pressure started to drop. I'm pulling out my lightsaber thinking, okay, it's time to actually decompress this guy. And I thought, well, let me take a look at his trachea. Because I remember one of the docs who taught me, Rick Verbeek, said that when you look at the anatomy of the trachea, the top of the trachea, the larynx is fixed. But as you go down the trachea, it's not fixed in the neck. So the actual trachea itself at the top. Uh-oh, I think we stopped again. Rats. Hang on a second. Let me go back to where you are. Are you there?
I am.
Rats. What did you last hear?
When you look at the
Okay. When you look at
the
Oh, right. Yeah. Oops. When you look at the trachea, it's attached at the top. So the larynx is attached, but as you go down in the chest, it's not attached. It's much more flexible. So when people have like a tension pneumothorax and the lung shifts over, the part of the trachea that moves is actually the distal part. And the furthest part that we're able to actually detect is just above the suprasternal notch. So if you feel down along your trachea, you get to the point where suddenly it disappears behind that bone. And that bone is kind of U-shaped. Well, it seems like it's U-shaped. It's the two collarbones, really, above the gladiolus of the chest bone. So if you feel on the 2 points at the top of that U, and then just gently push your fingers in, that's the lowest point of the trachea that you can palpate. So you feel there, and that's where you're actually going to feel whether or not the trachea is midline. A lot of inexperienced paramedics will look at the very top, they'll look at the larynx, the Adam's apple, and they'll say, oh, it hasn't moved. But that's not the part that moves. And I usually demonstrate that by like getting a pen or something and putting it just at the fold under my chin, and then I move the bottom of the pen. And I
there's
say,
not a lot of movement. There's not a lot to see.
yeah, the larynx doesn't move.
No.
It's the distal trachea. And so if you feel down to the bottom, that's the best way to actually detect for that. I don't let my students visualize midline shift of the trachea. They have to palpate it.
Yeah, agreed.
So
Yeah.
midline trachea. N is nocturnal dyspnea or paroxysmal nocturnal dyspnea or any other orthopnea. And orthopneas, like paroxysmal nocturnal dyspnea, or just PND is an easier way to say it, are difficulty breathing when you are in a supine position, which is what we were talking about before with that nursing scenario that I did. So ortho means straight or vertical in Greek, and pnea means to breathe. So orthopnea means it's easier for you to breathe when you're straight up or vertical. And paroxysmal nocturnal dyspnea is this situation where people who have a lot of fluid accumulating in their legs and, dependent parts, they lie down flat in bed at night and that fluid shifts up into their lungs. And about half an hour or 40 minutes after they go to bed, they wake up and they can't breathe. And they've learned that if they sleep sitting up, and we call this pillow orthopnea, people have like 7 pillows. If they're sleeping sitting up, then it's because they have too much fluid, and the fluid goes into the lungs when they're sleeping. I have had patients who, and you've probably had this too, who sleep in
Yeah.
lazy boy chairs
Yeah.
because the fluid just goes into their lungs if they lie down. So usually this is due to some sort of heart failure, or in the short term, maybe some fluid overload or an inadequate diaphragm if they've had some sort of neural problems with their diaphragm, some paralysis, or obesity hypoventilation syndrome, the Pickwickian syndrome, that sort of stuff. So sometimes you'll see this. I'll tell you a quick funny story. I was teaching about this in the Middle East, about paroxysmal nocturnal dyspnea, to people whose second language or third language was English. And I thought, oh my, they're just never going to get this, right? Like, I'm translating from Greek into the English, and I go through the whole thing, and I'm so careful explaining about, paroxysmal. Paroxysmal means unexpected, nocturnal means night, dys means bad, pnea means breathe. Like, I went through the whole thing, and I wrote it out on the board. I finished the lecture. I said, so you guys get what I mean when I say paroxysmal nocturnal? Yes, very clear. Thank you, Mr. Mark. Thank you. And I said, they said to me, one question though. I said, sure. What's that? I said, what is pillow?
What do they call it? Cushion.
It's like, how far back do I go with? But I mean, kudos to these guys. They're learning medicine in a different language,
Yeah,
it was
wow.
great. But I just didn't think to translate pillow. So that's P, and the P is for paroxysmal nocturnal dyspnea or any other sort of orthopnea.
Okay, so now we're going to talk about O being for oedema. And in particular, we want to talk about clubbing in fingers and things like ascites.
Yeah.
So ascites is where you get a buildup of fluid, and it's generally related to heart failure patients, but it could be because of other things like cellular tissue breakdown and things like that cause an actual peripheral oedema in the actual tissues themselves. But generally, when we talk about oedema and ascites, it's usually due to a heart failure problem.
Yeah, or liver disease, right? We don't make the albumin anymore, and we can't keep our osmotic pressure. Yeah.
And that's where we get things like hepatomegaly. Well, that's what we say, hepatomegaly in Australia. And so you get an enlarged, what do you say, hepatomegaly?
Hepatomegaly.
Yeah, megaly. Yeah, we say megaly. I think megaly sounds fancier.
It does, yeah.
Yeah,
It's a bit more elegant.
That's it. So that's when you palpate and you'd feel an enlarged liver, and that's, a sign of liver disease, and ascites is usually a byproduct of that.
Yeah.
So also with ascites, you can get a condition called anasarca. So that is like an extreme generalized edema. And I have seen a couple of these. One patient in particular really stands out. It's someone that we visit yearly on a regular basis. Is a person that allows us to examine him as a part of our course. And
Oh, wow.
I like to think that he's still around, hopefully. Every year we go back, I'm always crossing my fingers that he's still there.
Oh, gosh.
Yeah, he has really extreme heart failure, and he has this anasarca, and it's all the way up to basically the nipple line.
Yeah, yeah.
And it's extreme. So it's
Toes to nipples. Yeah.
it is. It's completely fluid all over his body, and,
Wow.
and there's no place left untouched, basically from here down, that is not visible fluid. And even though they control his fluid intake and his fluid tablets, things like furosemide, etc., they control them, but it doesn't really make that much difference once you get to that kind of point of failure.
Yeah.
You'll always, teeter on that real balance of being, a problem. The other thing I wanted to show you is a thing called Shamroth sign.
Yeah.
So it's where you get a clubbing of the fingers and the fingernail. So with Shamroth sign, I can't kind of do it, but basically the ends of my fingers change shape with long periods of time of being hypoxic. So you actually get the nail beds and the shape of the nails change with long-term chronic respiratory disease. So if you ask the patient or the person to put their fingernails together, you'll actually see that there's clubbing in the ends of their fingers, which is a really kind of identifiable sign of long-term chronic respiratory problem.
Right. And the spooning as well, right? That's the other thing that we'll see
yeah.
from the side, because they're chronically hypoxic because they're so far from the heart. So you get that angiogenesis of more blood vessels being created, which sort of squishes the tissue out there. And their fingers start to look like spoons. And like you said, when you touch the tops of the nails together, you can't see that little window through there anymore. If you're like a healthy listener, take your pointing fingers and touch the two nails together, and you'll see there's a little window there. And that's normal. That's a normal, they call that Shamroth's window. And when you get your fingernails swelling, you lose that little window. So that's something to have a quick look for. Oh, edema, including clubbing of the fingers.
Correct. And P is for?
PEEP. And PEEP stands for positive end expiratory pressure. And it's a way that people breathe. And if you've ever seen a COPD patient, you'll know they talk to you like this. And at the end of the breath, every experienced paramedic is now nodding because they know that somebody will talk to them like this. And what they're doing is they're actually putting end expiratory pressure at the end of the breath so that their lungs stay inflated. Because when you're emphysemic, I remember one mentor telling me, basically their lungs have turned into old plastic bags. And they just, they're floppy and they collapse. So if you finish the breath like this, and then you stop and you maintain that pressure in your breath instead of just going at the end, when they go, their lungs collapse. And so they finish their sentence like this and they're peeping. And sometimes they'll even be talking to you like this and through the pursed lips. It's every COPD patient you've ever seen, right?
Yeah.
That's what they're doing, is they're maintaining positive pressure in their airways. So at the end of an expiration, so that the airways don't collapse. And that's usually in adult COPDs. In kids, you might see grunting sometimes as they breathe like that. And again, they're, doing extra work and they're exerting themselves, but they're also maintaining that positive pressure at the end. So P is for PEEP.
Q is for queer.
Yeah.
I like the fact you had to put the queer in there. That's fantastic.
Well, I'm trying to think of, how the odd presentation, the
odd.
atypical, but Q is a difficult letter to match. So the queer presentation
You've
of
done well.
COPD. Thank you.
Yeah. So with this, we have the two categories. Now, you'll be familiar more with this. It's an old-fashioned terminology.
Yeah.
The pink puffers and the blue bloaters. So we talk about COPD presentation. So blue bloaters being blue bloaters bronchitis.
That's how I remember it too.
Yeah. And pink puffers emphysema. They don't match up, but I always remember blue bloater, bronchitis. So remember chronic bronchitis. We're not talking about, the bronchitis that you get once a year. We're talking about, chronic bronchitis is actually, there's, I think is it 2 episodes I can't remember now, but there's actually,
there's some sort of time requirement.
Episodes
over a certain amount of time.
Yeah. And so it's, it's caused by excessive mucus production, breaking down of the tissues, and causing airway obstruction. So the actual capillary bed, the alveoli area is actually okay. It's the bronchioles, bronchitis, that's, the bronchioles themselves are what's actually affected, as opposed to something like emphysema, where you'll get a coalescence of those alveoli. So all of the little grapes, the alveoli that are together, they all start, the linings of them start breaking down and they coalesce into one big grape, as opposed to having like lots of little grapes. So,
and that's where you surface area.
That's it. And also the nice elasticity and compliance that makes the lungs go in and out.
Right.
With emphysema, you have more of a problem with the actual breathing and compliance, whereas a blue bloater, bronchitis, it's more of a problem of all that extra mucus and coughing up infection and, all of the bronchioles being inflamed and the plugging and the mucus that's caused by them.
Right. And that causes the hyperinflation, which is the bloating part.
The bloating part,
That's
of course.
Right. They've got those big barrel chests.
Yeah. And, the blue bloater and, of course, the colour, causing actual cyanosis. So the blue bloaters actually have periods of normoxia, so normal levels of oxygen. And then when they become hypoxic, they go blue. Whereas an emphysemic patient, they're normally able to regulate their levels of carbon dioxide and oxygen still okay, with alterations in their breathing pattern.
They hyperventilate. That's the puffer part.
Exactly. And they create their own PEEP.
That's right.
So they can actually physiologically counteract the actual disease process, whereas a bronchitis patient can't do that as well. That's right. So that's why we end up with the colour differences. The bronchitis patient, hypoxic blue, emphysema, okay in pink, all right? So you get the pink puffer versus the blue bloater.
Right. So the next one is R, but just before we go on to R, one of the things that's interesting about this is starting at N, which is the nocturnal dyspnea and the orthopnea, or the O, which is the edema and the clubbing, and the P, which is the PEEP, and the Q, which is the queer presentation of COPD. N, O, P, Q are all generally COPD manifestations.
Yeah, they are.
So that's a way to, it just happened like that by accident, but they just sort of coalesced into one part of the alphabet in this mnemonic. And so the N to Q are ones that we wouldn't really look for necessarily in an asthmatic or something like that. You're not going to see a blue bloating asthmatic, for example. But those NOPQ, if you remember that those are the typical COPD presentations, that's kind of helpful.
Yeah.
Then we get to R, and R is probably one of the most obvious ones, and that's the rate and the depth of their breathing. So their respiratory rate and their tidal volume. And we've got a few words that, paramedics should be familiar with. So we'll say, pnea means breathing. U means good. Eurythmics, one of my favorite bands from the 80s, means good rhythm.
Yeah.
Dis means problems, tachybrady means fast, hypo means slow, and A means without. So when we add all those prefixes to pnea, we get eupnea, which is breathing well, dyspnea, which is breathing poorly, tachypnea, which is breathing fast, bradypnea, which is slow, hyperpnea, which is breathing deep, hypopnea, which is breathing shallow, and apnea, which is not breathing at all. So when we assess our patients, we're taking a look at how fast are they breathing and how deep are they breathing. So tachybrady and hyper, or it's fine, eupnea, or it's absent, and that's apnea. So those are useful terms to have. And of course, we'll add numbers to these. So for the rate, we really should be getting a respiratory rate. And like you said, we're really bad at this. And there's a lot of research that shows that this is the worst vital sign that we do. Really, if you want to get a respiratory rate properly, I think you should be auscultating. And what I do is I tell them, I'm just going to listen to your heart. Just breathe normally. And then I listen and I look at my watch and then I'm just listening to their breathing. And they don't worry about their breathing. If you tell them you're listening to their breathing, they start to become very conscious about it. I say, I'm just going to listen to your heart. Just relax and breathe comfortably, just normally, because I'm just listening to your heart. And I lie.
Do you find though, if you say just breathe normally, they automatically go, what's normally? What's breathing normally?
Well, yeah. Don't worry about your breathing. I'm just going to listen to your heart. So just relax. And then they're fine.
That's a good way of saying it.
So that's R. That's the obvious one, the rate and depth. You'd think we'd put that first, but I kind of fit it in R. As long as you do them all, you'll get them.
Well, that leads us to S, which is spirometry. So, over the last, let's say 5-10 years, pretty much every truck now carries a spirometer.
Depends on the system, I think.
Does it?
Yeah, but often the patients will have one.
Yeah, well, I know that New South Wales and ACT they were coming into New Zealand, so and I don't think that they're expensive.
Right.
It's really just like a toilet roll on a flow meter.
Yeah, with a little flow meter, yeah.
Yeah, so they are fairly inexpensive piece of equipment and they are very good to have. So spirometry is the actual measurement itself of what the person can blow is not, between Mark and I, we're going to be completely different. But what is normal for me is normal for me, and what's normal for him is normal for him based on the size of the person and the lung volume that they've got, their vital capacity. So
we're comparing to baseline. That's their baseline. We need to know what they're normally like. Yeah.
Yeah. And, people who are asthmatics or who have chronic respiratory disease quite often will have their own spirometer and they'll know what's normal for them.
Right.
And it's about the change over time. So what they can do today or what they can do after you've given them something like Ventolin.
Right.
So you'll get them to blow into the spirometer.
Yeah.
And then you'll instigate some kind of action or a medication, and then you'll remeasure it to see if you've had an improvement. And, with the spirometry, there's a couple of, terms that we talk about. We talk about the peak expiratory flow rate,
right,
which is
that's
the amount.
The big one, yeah.
That's the actual, the force that you can achieve on that big.
How much can you get? Yeah.
How much can you get? So, and that's the value that's relevant to me, and the relevant to Mark. And that's the one that we want to know that changes over time.
And that's in liters per minute, right? Like what's the fastest flow that you can get?
Do you know what yours is?
No, I don't.
Any chance?
Actually, no, I don't.
Yeah, I think mine was around 400 or 420 or something.
Wow.
Um,
Okay. That's a lot of
in
liters.
So after peak expiratory flow rate,
Mhm.
there's also a ratio that we like to talk about too. So it is the FEV1 versus the FVC ratio. So
Got to
FEV1,
explain that. Yeah.
yeah, is the forced expiratory volume in 1 second,
Right.
right? And FVC is your full vital capacity. So that's the amount that you can breathe breathe out after a
Right.
big breath in. So you have normal tidal volume, which is just like normal breathing, and then you have, total lung capacity or total vital capacity, or the full amount that you can breathe in, which is forced inhalation and forced exhalation, the most that you can get in and out. All
Right.
right. So what we want to compare is the ratio between the two, the actual forced volume in 1 second versus what I can possibly do on a big breath in versus out.
Right. So how much of your full lung can you blow out in 1 second?
Exactly.
Right.
Yeah.
Got it.
Which is a really good comparison to really look at, because it kind of gives you, it's about obstruction. So if I've
Yeah.
got a problem with getting the air out, like in asthma, it's going to take me a lot longer to breathe that air out.
Hmm.
So what's normal for me when I'm not having an acute asthma attack, or compared to my normal breathing, when I'm having asthma, will be really different, because asthma is a problem with air trapping and trying to
Right.
get the air out.
So what
So
percent
looking
could
at
a
this,
normal person normally breathe out? What percent of their full capacity could they breathe out in 1 second?
could they possibly breathe out, is around 75%.
Yeah. Okay.
Yeah. And then it'd be like,
Yeah. So if
yeah,
we drop below 75%,
yeah,
that's where you
that's
start
right.
going right. Yeah.
That's when you start thinking that they've actually got a problem with getting the air out. Yeah.
Yeah.
We're starting to suspect some kind of obstructive disease process.
Now the problem, of course, with the peak expiratory flow is just a quick breath, and that's easy to do. But when you start asking people to do a full inspiratory breath and then blow it as much as they can, well, people who are really short of breath can't do that. So
Yeah.
although the FEV1 over FVC gives us more detail, it tends not to be very applicable in emergency medicine until they're
Mm.
getting better. The peak expiratory flow tends to be the one that we use the most.
Yeah, and that's still relevant. You
Yeah,
can
it's
still
great.
take that reading, do some treatment, do it again, and quite often now in the guidelines, it'll talk about using the spirometer and getting a reading on the spirometer, trying to find the book, if the patient keeps a book, a record
Right.
of their normal lung function, looking at and comparing it to the old.
Good idea. Good
Yeah.
idea. And bring in their peak flow meter with them so that as the
Yes,
measurements or as the treatments are done in the hospital, they've got the same baseline device for measuring.
absolutely.
Yeah. Yeah.
They're
It's a
not
good one.
always calibrated the same way, or they're not always exactly
That's right. We're
correct.
really looking for the change. We don't care how many liters it actually is. We just
Yeah,
want to know if they're getting better or worse
yeah, that's
as
right.
compared to the normal. Okay. So that's S, spirometry, measuring. T, we're getting into the Latin because in Latin, I'm reaching here, but we're doing
Yeah.
it. Tussus means cough, like pertussis, right?
Hmm.
So Latin for cough is tussus. So when we're saying T, we're asking about coughing, really.
Mm.
So, have they been coughing? Have they had tussive episodes? And if they are coughing, we want to know, well, what's it like? And the big difference we want to know is the difference between a dry cough or a productive cough. So, the dry cough is the, something like that. The productive cough is like the smoker getting up in the morning,
Yeah, coughing along up.
Yeah, I call it, are you coughing up green eggs and ham? And
Yeah,
that usually
yeah.
gets people. So if it is productive, what are they actually producing? What are they spitting out? Is it like a white normal sputum, or is it a dark green brown purulent tenacious sort of, the green eggs and ham type of
Mm.
thing, which would indicate an infection? Or concerningly, is it hemoptysis? Are they coughing up blood? Is there red tinge to the sputum that they're coughing up? Because
Mm.
that makes, there's a lot of possible causes for that. It could be cancer, some sort of neoplasm or something. But the one that really worries me is tuberculosis. So
Mm.
here's a quick rule for everybody out in the field to protect yourself. If your patient is hemoptic, if they're coughing up blood, you put a mask on them and let them breathe some oxygen regardless of their SpO2, because when they cough, it goes inside the mask.
Mm.
And TB is a droplet
Hmm.
infection. So I put on my N95 mask and I throw one up to my partner and I say, you put this on too, because I don't want tuberculosis.
No,
Yeah.
no,
So that's
absolutely.
the T. The U, and if you are listening to this, please don't complain about this because it's the only way I could make it fit.
I like the fact that you made it ugly. You made me talk about you for ugly.
Wait, me? You calling me ugly?
I think it's quite creative. I think it's very creative and we're finishing on a high note,
Yeah.
on an ugly note,
My
which I think is kind of
apologies
cool
to
too.
all
No.
smokers.
Okay, yeah, all right. So we're talking about cigarette smoking here.
Right.
So the ugly is smoking. Okay, so we are looking for signs of a smoker. So the smell of smoke,
Right.
the smoker's face.
Well, you know what? There's actually a paper published, and I've got the notes here, so it's not like I've memorized this and I'm brilliant. But in 1985, someone by the name of Model published a paper. It's on PubMed. You can go take a look
Yeah.
at it, called Smoker's Face, an underrated clinical sign. And I've seen this in charts. They have smoker's face. The
Really?
craggy, yeah. It's a term in medicine. I didn't
Oh,
make it up.
I think that's really quite cool. So
Yeah.
I can imagine what that might actually look like.
Sure. Imagine somebody
The
who's 70 who's been
smokers.
smoking their whole life.
Yeah. You get
Yeah.
that.
Gray, deep crevices,
Yeah, the deep
saggy
crevices around the
skin.
mouth. Yeah, but
Yeah.
it's also the skin itself is different on smokers, I find.
Yeah.
Over
Sure.
time, they lose their elasticity and they get a
It's
more aged,
distinctive.
prematurely aged.
Yeah.
Yeah. Stained fingers, that's the obvious one.
Yep.
Stained teeth, stained facial hair, like around the lips if they've got a
And the
moustache.
mustache or the forelock. Sometimes people who have lots of hair on their head from the cigarette smoke coming up, they'll have that smoker's forelock. The
Yeah.
little colored, yeah.
Yeah, the change, smoker's breath. I can
Yeah.
smell it a mile away.
Oh, yeah.
Being an ex-smoker, I think you're always
You
more.
are?
I am. Yeah, I started
Oh,
smoking when I was 15. I think I gave it up when I was
shocking.
25
Oh,
though.
good for you.
But yeah, the actual smell now is something that you'll never forget because
Right.
I think ex-smokers are far worse than
Yeah, they're
non-smokers. Like
born again, aren't they? They're
oh
like,
yeah,
yeah,
yeah. I
really
think I've calmed
fundamentalist.
down these days, but
That's
back in
good.
the old days, when you first give up smoking, it's really hard.
Yeah,
So that smell is just, you just want to
yeah.
run and hide. So yeah, so anything, and obviously they might have a pack of Winnie Reds rolled up inside their shirt or in their pockets as well. So,
Winnie
the
Reds.
obvious, that's it, the
Too
obvious
right, mate.
signs. Yeah, and all of those things, the associated respiratory problems that go with smoking, you do
Yeah,
tend to put these together.
the COPD. So here's what I'd like to do now. That's it. We've got up to you all the way. So we've gone A to you. What I'm going to do now is I'm going to give you, Sonia, and the listeners a presentation. I'm just going to go through, accessory muscle use, breath sounds, condition of the skin, word dyspnea, extending, finger, entitled gas. I'll do all of that in order. I'm not going to say anything about the nature of illness or what they're complaining of or anything like that. I'm just going to give the signs. And as you listen, I want you guys listening to see, can you figure out what's wrong with this patient?
All
So,
right.
and you can tick along with the ABCs as we go if you want. I've got a 23-year-old patient found short of breath using accessory muscles with bilateral inspiratory, expiratory wheezes from the apices to bases. Skin was pale and cool, 3-word dyspnea, which should make your sphincter tighten. She was found in a tripod position, self-supporting on a chair, starting to slump, 86% on room air. Initial CO2 was 64. We didn't talk about numbers, but 35 to 45 is normal. So this is high. CO2 was 64 with a bronchospastic waveform. Heart rate of 118 at rest. Inspiratory-expiratory ratio of 1 to 3. JVD to the jawline while tripoding in high Fowlers, so sitting up high. No Kussmaul's or other abnormal respiratory pattern. Alert, but clearly exhausted. Trachea midline, orthopnic when supine, so very short of breath when lying down. No peripheral edema, no PEEP, no evidence of COPD. Tachypnic at 22 with hypopnea, so panting a little bit. Peak flow on their own home meter was 60% of their normal. We've brought the meter in with us because we're good paramedics. There's no cough or other signs of infection. Not a smoker.
Wow, that's comprehensive.
It really is. If you do that
Mm-hmm.
ADU, man, you've really nailed it. And then you add
Mm-hmm.
in the history with this patient, whatever it might have been. This really leads you well into your CPG. It tells you what
Mm.
you need to do. So, what's your diagnosis, doc? What would you say is going on with this patient?
There's a few things going on that are very concerning. Like to me, the wheezes,
Yep.
accessory muscles, and bilateral wheezes.
Yeah.
Okay, which is
Apices to bases.
that's it. Yeah,
Yeah.
and then you've got hypoxic. Yeah, the IE ratio is prolonged expiratory phase,
Yeah.
right? Which is, always leaning me towards asthma.
Right.
And the fact that it's got a wheeze, and
Yeah.
then they're hypoxic, and they've got no evidence of COPD, I would be leaning towards asthma.
Yeah. Definitely. With that bronchospastic waveform on the end tidal
That's
CO2,
it.
it helped nails it. And then you notice
Absolutely.
that I think we said we didn't talk about blood pressure, but I wouldn't be surprised if this patient was starting to become hypotensive because they've got JVD to the jawline
Yeah,
while
yeah.
they're sitting upright. So the lungs are starting to get so hyperinflated that they're starting to squeeze the heart. So this is pretty close to a dying asthmatic. This is a pretty sick asthmatic.
Yeah. And look, that's if I wrote that on my patient report form, that would be very, very good.
That's a
Be
compelling
very,
story.
it really is,
Yeah.
I'm sure most handovers would be awesome if they were done like that, and patient report forms, you'd be highly commended within your service. You feel that well done.
Yeah, again, well, if you've got that ADU format reported, you just write it down in that format
Yeah, you write the story, hey?
and it tells itself.
Yeah, yeah. Okay, well, I've got one for you now.
Okay, throw me one.
Okay.
Give her.
All right, it's a 76-year-old male
Okay.
found short of breath. He is using his accessory muscles. On auscultation, he's got coarse bronchi bilaterally, apices to bases, more pronounced on expiration though.
Okay.
He's got 6-word dyspnea. He wasn't tripoding when we got there. His sats are 92% on room air, end tidal CO2 of 84
Ooh.
with a normal waveform. So
Okay,
a normal
not,
shaped waveform.
not bronchospastic.
So there's no signs of bronchospasm there.
Okay.
A heart rate of 90 at rest.
Fast.
His IE ratio is 1 to 3.
Okay.
He's got normal JVD, a normal respiratory pattern. He's alert, aware. I think I said the trachea is midline. He uses 6 pillows at night time to prop
Okay.
himself up. He was orthopnic when we laid him back on our stretcher. He didn't like that. So
Getting the picture. Yeah.
Yep. He had auto peep, so he was kind of doing his own kind of thing.
Mark, Mr. Paramedic.
Yeah, you did it so much better than me. Okay, he's bradypneic at 10
Right.
and hyponic as well. Okay.
So hyperpneic. Yeah, okay.
Hyperpneic,
So
yep.
deep.
Yep.
Okay.
Deep bus. He looked a bit like a blue bloater.
Yeah, that's what I'm thinking. Yeah.
He has home forced expiratory meter, and he's sitting at about, he's got his own one, and it's sitting at about 60% of his normal capacity.
Should be 75, right?
Yeah.
Yeah.
He has a rattly, non-productive cough
Okay.
that tends to shift when you get him to, so if you listen to it and then he coughs and you put your stethoscope back on, it seems to have cleared a little bit.
Yeah.
And he's been a smoker for 30 years.
Yeah. I mean, wow. How can you? I mean, I'm listening to this, and I'm sure if you're an experienced paramedic, you're going, could you slap me across the face with a wet fish any harder? It's just so obvious. If you're new to this might be a little bit difficult for you, but this to me sounds like your COPD, or if he's a blue bloater, he's got that big anterior posterior chest ratio and he's got good color. This is a classic bronchitis patient. And, a few things that I was listening for is I'm wondering if he's got a productive cough, if there's maybe something infectious. No, but he's 76. He's a 30-year smoker. He's probably more than a 30-year smoker. He's got that failure element with the paroxysmal nocturnal dyspnea. He's tachycardic at rest. He's got low sats on room air. He's got high end tidal CO2. He doesn't sound like he's actually in a whole... like a lot of distress in terms of decreasing LOAs or anything like that. But he's, 6-word dyspneic.
Yeah.
He's not tripoding. So, I mean, this is a chronic bronchitis type of picture. If you're a student, you will see this guy a million times in your career. We just go and see them over and over again.
Absolutely.
Okay. I'll give you one more and then we'll wrap it up.
All right, go.
42-year-old male, found short of breath. That's the price of admission to these scenarios. So he's got mild accessory muscle use, localized inspiratory, expiratory crackles in the left lower lobe only.
Ooh.
Skid is red, febrile to the touch, mildly short of breath, 10 to 15 words per sentence, so not really bad word dyspnea. He's not tripoding. Satting 93 on room air, end tidal CO2 of 40, so right in the middle normal. No bronchospastic waveform. Heart rate is 86 at rest, bit high. IE ratio of 1 to 2, which is good. And no abnormal JVD. He's got a eupnic respiratory pattern, so no Kussmaul's up in your stick,
normal.
nothing like that. Yeah, all normal. He's alert. Trachea is midline, denies all of the COPD stuff, PND or orthopnea. Has no clubbing, no edema. He's not peeping. There's no evidence of CPD. He's slightly tachypnic. He's got a resting rate of 16 with a normal tidal volume. He's got no home spirometry equipment, which is kind of diagnostic. It means he's probably not an asthmatic or a COPD. He states he has had a cough that's productive of viscous, green, purulent sputum for about 2 days, coinciding with the onset of shortness of breath and fever. No history of smoking. Oops. I'm so excited that I just smashed my my microphone.
It's very much lung, pleuritic, and it's got a fever that goes along with it. You said he was febrile and he's coughing green things. It's got to be pneumonia.
Yeah. And that localized inspiratory, expiratory crackles in the left lower lung lobe only. That's your infectious loci. Now, don't be surprised.
Kind of thing. That's the thing that will get people, though. It's not bilateral. So it's not edema. It's not pulmonary edema. It's to one side. There's a temperature that goes with it. There's a productive green, horrible infection thing that goes with it too.
He's got a lobe full of pus in his lung.
That's it. It's pleuritic. So pleurisy, pneumonia, that kind of.
Yeah. This is an infectious. This is a respiratory infection.
That's right.
Good. So, we covered a lot, right? We've talked a little bit about how to interview the patient and given you the outside to inside format. And we've given you the A to U. And those should organize you. Generally, paramedics work in teams, not always, but one paramedic will be talking with the patient, and that's the primary, and they'll be thinking about that gas flow from the environment down to the cell. And the other paramedic, the secondary paramedic, will be doing the physical exam. And they'll probably go in a head-to-toe format, but they'll be making sure that they get the A to U. A lot of information in this podcast, but if you study it and you master this, honestly, you'll just be golden. So,
but you've got to say, respiratory has got to be one of the biggest ones we do, though, isn't it?
Sure, it is. I mean,
it always breath,
is. You'll get that almost every day.
Yeah.
So, thank you to you guys for listening through another one with us. It's always great to have you here and be able to share this. We're really interested in your feedback. So,
make sure you come and visit us on paramedicine.com.
Absolutely. Or you can email us if you want at contact@paramedicine.com.
Yeah, and follow us on Twitter and at paramedicine.com as well.
Yep. You can get the podcasts. Obviously, you're already getting the podcast, but wherever you get it from, that's great to get it. But if you can go to iTunes and leave us a rating, then that bumps it up on iTunes and it makes it easier for other people to find it as well.
Yeah, true. And also we're on Facebook.
That's right. Paramedicine.com. So take a look for that. We're also on YouTube. Again, paramedicine.com. Just search that, and we're slowly putting up more and more videos.
Yeah. And don't forget, this is part of our bigger AP CPGs project that we're doing. So there'll be follow-ups to this and ongoing episodes on other assessments as well.
That's right. And that is it for this episode. Thanks for joining us.
Yeah. In the meantime, remember to keep on studying.
Keep on caring.
And keep safe out there.